Thank you very much for SINFA to give us this opportunity to share our experience with our colleagues. It is a very good opportunity to be with Dr. Osama and with SINFA company in the same webinar. This is a very good opportunity for all of us. Thank you very much. Bismillah, inshallah, we'll start. ACL deficient knee is not a new topic to speak with, but I just want to say why I select this topic to speak. All of us like sports. Even these young chaps with this over 70 years old playing sport, like sport either as a participant or as a fans. All of us like to watch sports and enjoy watching, enjoy participating, even as a fan or as a participant, as I said. And at the end of the day, we are very happy when we find our champion raising the cup or has a tournament, and at the end we are very happy. But sometimes different scenario occurs. And at the end of the day, we will find one of our stars is carried over the couch and came out due to injury. That's why we select the sport injury as a topic. But why the knee, especially I selected? Because the knee is the most common joint injured during sport. If you can see from these slides that in UK, the most common joint affected is the knee. And in soccer player, the most commonly affected one is the knee. In US, over than 6 million sport-related cases diagnosed over the 9 years, the knee was the most commonly affected joint. And not only the knee, but the ligamentous injury are the common part of the knee to be injured. Among, as we can see in the chart, that the ligaments injury represent around 40%, and over than 46% cases of the ligamentous injury are the ACL cases. That's why I select the ACL injury as the most commonly seen injury among the sport, and it is the most famous injury, and some people counting down before when the patient have ACL injury. As I mentioned, in US, around 200,000 cases recorded annually, and half of them usually passes to ACL reconstruction. And 70% of the ACL tears occur during sport activity. The common age group to be affected ranges between 15 to 45 years old. These are the commonly affected group of athletes suffered from ACL tears. In children, we usually see avulsion injury, not soft tissue injury. It is avulsion injury with piece of bone. And not strangely enough that females are more affected by ACL tear than males if they are participating of the same type of sport. As I mentioned, like if we count female in football and male in football, we'll find that the female are more liable to get injured than males. Just a quick review about the ACL. As we know, it is an extrasynovial and intra-articular structure. It has attachment from the tibia to the femur. Tibia, it is from the intercondylar eminence, and from the femur, it is attached in the lateral femoral condyle on the medial surface, most posterior part. ACL mainly formed of two main bundles, anteromedial and posterolateral. The blood supply of ACL is mainly from the genicular artery through the ligamentum mucosum, but it has small part of blood supply from the bony attachment. It has proprioception receptor. Then what is the function of ACL? As all of us know, ACL is the main restraint of anterior tibial translation. It prevents anterior tibial translation. It has a secondary role or second restraint against valgus or varus abnormal movement. It helps to smoothen the sudden change from flexion to extension and from extension to flexion of the knee. During this sudden change of direction, the ACL smoothens this movement. We find that when ACL tear happens, this is between sudden flexion, sudden extension. This is the zone where giving way occurs. I just put this goal of Muhammad Salah to show how Muhammad Salah changes direction suddenly from one way to another way. This is the main function of ACL, to give stability of the knee during sudden change. And this is the main defect the ACL deficient patient complain when he suddenly change from one direction to another. This is the defect happens to the patient who have ACL deficient knee. How ACL get injured? To be injured, we have to have trauma. Because although it is very simple to understand that, but nowadays from people, a lot of people speaks about ACL, we can find the patient came to the clinic and say, "Doctor, I'm afraid to have ACL." He have no trauma. So ACL cannot injure without trauma. How ACL happened, how the trauma happened, we classify trauma into contact trauma and non-contact trauma. Even contact trauma is even sub-classified into direct and indirect. Direct if the trauma is directed to the knee itself. Indirect contact trauma if the trauma to any other part of the limb apart from the knee. But both are contact trauma. This is an example of contact trauma. We can see how vigorous the trauma is. But as I mentioned, it can be by indirect or by non-contact trauma, as we can see here, Ronaldo, the famous athlete. We can notice that no one without him, no one touched him even. And then he get this injury. Again, no one in the video with him. He is totally alone. This is what we call it non-contact trauma. Then what are the mechanisms usually give us this ACL tear? We have many common mechanisms. Just we will mention most commonly one, twisting injury. This twisting happened. This is the mechanism how the ACL get injured. Maybe this video show us how this happens. What happened during twisting? We have this valgus abduction, external rotation. This is exactly what happened during twisting. Stretch of the ACL, then get tore, and we can notice that during this twist, during this vigorous stretch of the ACL, it get torn and it landed over the PCL. That's why in the old days, we was missing the diagnosis, even the MRI, at the start of the MRI. This is, sometimes we cannot clearly see that the ACL is torn. Another mechanism is the valgus injury. As we said, it is the secondary restraint against valgus. So during valgus, we will find that the medial ligament gets stretched, get torn, and then the ACL gets stretched and they get torn. As we can see here, the direction is going till it tears the medial ligament, then it affects the ACL. This is an example of the valgus injury. I'm sorry that the video is very vigorous, but this is actually what happens. Sometimes there is another, although it is infrequent, but happens, which is hyperextension. During extension, most of the ACL is stretched. During hyperextension, this overstretch gives us the tear. We can notice here how hyperextension happened. Oh, then the ACL get torn. Sometimes it is like that. Usually it is landed over one limb from like this also, Rahim. He landed over one limb, then get hyperextended, then get the ACL. So how we classify ACL injury? According to the time, we may say it is acute or chronic. This is at the time of presentation of the patient to our clinic, or when he asked for advice. Sometimes we can classify it, is it complete or incomplete? As we can see here, this is complete there. This is complete there. Sometimes it is incomplete. Sometimes we classify it according to the site. Is it mid-substance or is it terminal? Is it avulsed? Yeah, and most of the time, this classification, is it mid-substance or terminal? Maybe nowadays they spoke about repair if it is terminal, but until now it is not proved that it is effective for repair, as we will see later on. Sometimes we classify it according, is it solitary injury or associated with other lesion? Usually the vigorous trauma will affect one ligaments as a start. Then sometimes it continue to affect the other ligaments, and sometimes it continue to affect the menisci, sometimes it affect, and how much the trauma proceed, this is the result of the summation of the trauma, how much it will affect. Is it single ligaments, more than one ligaments, more than one ligament with menisci, with other injury? This is what we call it solitary or associated with other injury. How we diagnose this problem, how we diagnose this is as any medical problem, we go through the history, examination, and investigation. The usual scenario of the ACL tear, we have vigorous trauma. It is not simple trauma. Vigorous trauma followed by inability to walk and rapidly accumulating swelling. This is the most common scenario. Vigorous trauma does not mean it is contact, but I mean it needs force to get torn. Either forced by the body weight, forced by the torque, forced by the torsion, forced by direct or indirect, but it needs vigorous trauma to be torn. After that, the patient will suffer from severe pain and rapidly accumulating swelling. Sometimes it's associated with muscle spasms that he cannot flex or extend the knee fully, but usually all this, it takes around 1 to 2 weeks, then it starts to settle down. After this settlement, what usually patients come to complain with is giving way. Giving way is the most common complaint after ACL tear. Sometimes patients came complaining from recurrent swelling or locking, especially if it is associated with other injuries. What about examination? Examination of any injured knee has to be thorough examination of all structure of the knee. We have to do inspection, palpation, range of motion, special tests, as any joint, as all of us knows. In inspection, we may find that the patient has deformity. Usually the knee is a little bit flexed. The patient, if have massive swelling, massive effusion. Usually it comes with the knee little bit flexed, and this swelling is usually from the effusion. Sometimes from the other direct trauma, there is color changes like ecchymotic patches. If it is chronic and the patient is not rapidly sought the medical advice, he may present with marked wasting of the quadriceps. As I mentioned, in palpation, we have to palpate every single centimeters in the knee to know where is the tenderness, to give us a clue about other injuries from other structures. Range of motion is very, very important to examine. Sometimes the patient came with locked knee. Sometimes the patient came with only from the effusion, massive effusion. He cannot fully flex or fully extend the knee. So the range of motion is very important, not only for the diagnosis, but also to start the management. Examination of cannot be completed without doing special tests for every structure of the knee. We have special tests for the ACL, for the collateral ligament, for the menisci, for PCL, for the patella, for posterolateral corner. We have to do all special tests for every single case of knee injuries. For the ACL, the most famous tests are the pivot shift with the functional test, Lachman test is the most sensitive test, and anterior drawer test. This is video show how we do this test, and they are positive in this case. This is a pivot shift. We gradually flex, and we will find that suddenly it pops out. This is exactly what happened during giving way. This is the Lachman test. We can do it in even acute cases. Maybe pivot shift would be difficult, and this is the anterior drawer. Anterior drawer and pivot shift is very difficult to elicit them in the acute phase. Lachman is more sensitive in the acute phase. As I mentioned, we have to complete the knee examination by doing special tests for the collateral ligament, valgus and varus stress test in 20 degrees and in full extension. We have to do menisci tests, which are McMurray and Apley. We have to do PCL tests like posterior drawer, recurvatum test. We have to do posterolateral corner dial test. All this has to be done. This is a quick examination of the knee. This is the Lachman test. This is the anterior drawer. This is a pivot shift test, as we mentioned. This is valgus stress test, varus stress test, 20 and 0 degrees. McMurray test for lateral meniscus. McMurray test for medial meniscus. And posterior drawer test. And the other picture is just showing the dial test for the posterolateral corner. X-ray is cost effective, although most of the time it is normal, but sometimes we will find positive signs. In the right side, as we can see here, this is a second fracture. Second fracture is very pathognomonic for ACL tear. I mean that if we saw second fracture, it is over the 90% associated with ACL tear. This is avulsion injury of the posterolateral corner. This is one of the very specific fracture associated with the ACL. Although second fracture, if we diagnose second fracture alone, it represents around 17% of cases of ACL. I mean that ACL cases, 17% of them has second fracture. But if you find second fracture, it is 90% has ACL tear. This is the avulsion injury of the tibial spine, which is the avulsion injury of the ACL. This is the finding we may find in the plain X-ray. But the gold standard is MRI. In MRI, you will find bone marrow edema, usually in the lateral side. There will be loss of the rural sign of the intact ACL. ACL is usually seen in the MRI from the origin to insertion, and it is straight like rural. We may find bone contusion as well, and we will find associated meniscoligamentous injury if present. This is an example. This is the normal in the left side. This is the normal ACL from its origin to its attached in the femur, and this is the rural side. Here we can find this loss of this rural sign of the ACL. We can find other injuries. This is a bone contusion we can see. We may be find as associated medial collateral ligament here. We may find associated with the meniscal injuries. What the management of the ACL deficient knee? I just want to confirm, to repeat every now and then that management of ACL is not a one-man show. It is a teamwork. Without teamwork, you cannot get the best results. Maybe I got this video to show how if we are working in a team, we will enjoy and we will score exactly in the proper time. Any one of these players can score, but if it is do it in a team, it is more sure that he will score and it will be more enjoyable. A lot of controversies for management. I'm very sorry for this very crowded slides. Anyone, when he saw this slide, said this is not a presentation. This is very, very crowded slide. I'm very sorry for that. But I just want to mention that the ACL management has a lot of controversies. Is it surgical, conservative? Is it, what about in children? What about in varus and varus knee? Timing of surgery, is notchoplasty is mandatory for all cases. Shall we do the femoral according to the portal from transportal or transtibial, how to fix it, or with CPM or without CPM, with bearing, a lot of controversies. That's why I'm just wanted to your share for this, Dr. Muhammad, if you can open the share for ACL tear management is only surgical. I mean, all cases of ACL tear need surgery. I just ask you to vote for this, please. If it is only surgical, please vote for yes. If there is any other role, you can say it is not only surgical. Waiting for your vote. Dr. Muhammad?
Yes, Dr. Mustafa, so far we have 39 votes. We're
waiting for to give us.
Yes. So for everyone, please insert your votes in the browser in front of you in the screen. Okay. I'm sharing results.
Oh, thank you very much. I'm very happy to see this vote, that it is not only surgical. I'm very, very happy to hear this. Because a lot of sound, a lot of surgeons now say, oh, ACL, surgical. Don't speak with me. It is only surgical. No, it is not like that. At least in my opinion. In my opinion, it is not. It's not only surgical. There is patient, we are not advised them to do surgery. So there is a role of conservative treatment. Yes, in my opinion, there is a role of conservative treatment. For example, patient refused surgery. He said, doctor, I don't like to do surgery. Okay, I said him, don't come back. I mean, no, there is. If he refuses, we have to accept that. If the patient has medical contraindication for surgery, we have to deal with that. If the patient have sign of ACL, but he has no disability, for example, I have ACL tear after the acute phase passes. I went to be examined for any other knee problem. Then the doctor finds that I have anterior drawer test positive, I have Lachman test positive, but I have no giving way. I have no giving way. I have no looking. Shall I push him to do surgery? In my opinion, no. There is a lot of controversies. People say, no. If you leave him without surgery, he will have osteoarthritis later on when he get middle-aged, and he will have osteoarthritis earlier than us. I don't accept this. I believe only that osteoarthritis, if it happens, there is another causes for this. I will discuss it later on. Also, in the acute phase, any patient with ACL, shall I take him second day to surgery? This is a lot of controversy. There is a difference between highly professional athletes like Messi or like any one of these. He got ACL. I cannot wait for him to get this acute phase passes. I may compromise. But for elective patient who came after 2, 3 days, 5 days of injury, I prefer myself to wait till acute phases pass and have full range of motion. Then I can take him to surgery. This is a lot of controversies, as I mentioned before, but this is my own opinion. There is also another controversies. If we have ACL tear in children, before closure of the physis, child has played, and during playing, although it is uncommon, but it happens. All of us, all of knee surgeon or sport injury surgeon, have many children who have ACL. I ask you to vote again. Dr. Muhammad will open the voting for if ACL tear happened in children. Are you with intra-articular reconstruction? Are you with extra-articular reconstruction, or conservative till it is nearly fusion of the physis? Then you will go and manage it as the adults. Waiting for your vote. Please vote. Just to clarify, I'm asking by intra-articular reconstruction, extra-articular reconstruction. Conservative means I wait till the age is nearly closure of the physis of the knee joint.
Okay, I've shared results.
Thank you very much. Also, I'm very happy to have this. Thank you. I'm accepting this, and I am with the 88% conservative with some concern. I will clarify this. This is the knee of a child. We can notice that there is a physis here, which is still open. What is the problem if we did intra-articular reconstruction? This means we will crossing the physis with the drill. If we cross the physis with the drill, this area where we cross, it will close early. And this will lead to trauma and will lead to gross disturbance of this child. That's why a lot of people say that. The controversies they mentioned that if it is the penetration happened near the center as in the tibia, we'll do the tibial tunnel near the center of the tibia. So it will not give big problems. But for the femur, we are crossing the physis near the lateral part. This may lead to later on problem. That's why this is intra-articular in the top part of the slide. We can notice that for the top part, they did not do that. For the downward, for the bottom one, we will find that this reconstruction, we find that this crossing the physis came here, but it crosses the lateral part, and this will lead to, before, when a lot of people studied children ACL reconstruction, before they were doing ACL reconstruction intra-articular, but after recording a lot of problems, they now, most of the pediatric surgeon, most of the knee surgeon, most of the athletic surgeon, even in children, they now postponing intra-articular reconstruction unless the child is near the closure of the physis. And many of the people who is doing surgery for children for ACL, they prefer to do extra-articular, or I mean it, extra epiphyseal damage. We can notice here in the top picture, in the left one of the top picture, that the graft passes proximal to the physeal plate. And we can see from the one on the right, they did not penetrate the femoral physis. They make it over the top without penetrating the physis. This, if I obliged to do surgery for children, I prefer myself to do extra-articular reconstruction. But I am with conservative treatment as much as I can till the child is near closure of the physis. Then I will do intra-articular. If I obliged, I repeat again, I will do extra-articular. This one of the controversies as well. What about acute phase? Acute phase, we have to do rest, splint, ice packs, analgesia, exercises to get full range of motion. I mean by exercises to strengthen the quadriceps and hamstring till I get full range, and then I will pass to either conservative or surgical. What about conservative? What we'll do physiotherapy brace and modifying lifestyle. What about surgical indication? Usually most of the knee surgeon, athletic surgeon, sport injury surgeon are with this indication. If the patient is young, adult, if the patient has associated meniscal or other ligamentous injury, it is an indication for doing surgery. If the patient is competitive athlete or professional athletes, this is no doubt we have to do reconstruction, we have to do surgery for him. If the patient is heavy labor, like people who are working in reconstruction of houses, we can ask them, oh, if you have giving way, come ask. He will, if you have giving way, he will fall from the fourth floor, then he will pass. So heavy labor, usually we prefer to do for them reconstruction. We call it high demanding knee, like military people. And if the patient have recurrent giving way or looking, this is an indication to do reconstruction. We cannot patient have giving way after physiotherapy and ask him to go conservative. No. Giving way means, persistent giving way means surgery. What surgery we will do? We will do ACL reconstruction. Oh, here we come to another controversies. Nowadays, they, again, every now and then, every around 20, 30 years, they come with, what about repair? What about suturing? Until now, glowing, suturing, in my opinion, until now, it is not convincing to do ACL repair. It is ACL reconstruction. That's why we said it is intra-articular, extrasynovial. Usually ACL does not heal. Until now, at least, we cannot find ACL healing properly functioning, because it's not only a matter of healing. We have to have healed ACL with good tension. Until now, the results of repair, I'm not convinced with, in my opinion. Maybe others. From where we can get graft if we do reconstruction, we have allograft or we have autograft. Autograft, we have the most common one is the hamstring or BTB. Also, quadriceps tendon can be used for graft, but usually quadriceps, we save it for revision. But the most commonly one used is the hamstring or BTB. Allograft, as I mentioned, sometimes we do it in acute phase, but it is weaker And if it is for young athletes, it is less in strength. If the patient have meniscal injury, we have to do it with the ACL reconstruction at the same setting. If it has fracture, we have to fix fracture, sure. This is from where we get the BTB, patellar tendon. We take usually the middle third, as we can see. This we take piece of bone from the patella, piece of bone from the tibial tuberosity, and the middle third. And hamstring, we usually take semitendinosus or semitendinosus gracilis and fold it 4 times to get this semit and gracilis, with or without, according to how much we need graft and how other ligaments is affected. Quadriceps, as I mentioned, we usually save it for revision, but not as a routine for a primary. For any ACL cases, we have to do a thorough arthroscopic examination before. If the patient is clear, we may take the graft, but if the patient has query, we have to do arthroscopy first. This is according if the patient have giving way, has very positive signs and MRI finding, I may proceed directly to get the graft and then proceed. If the patient's query, I'm doing arthroscopy first. But if you look to the arthroscopy and find the ACL roots intact, please don't forget to probe it thoroughly. Probing sometimes is a sure sign to have this ACL. As we can see here, this is a picture. It looks intact ACL. As soon as we probe it, we will find that it is torn ACL with empty hole sign. The probing is very, very important. The most important thing in the ACL reconstruction is where we do the tunnels. And this is, if the tunnel is not properly done in the tibia or in the femur, we are inviting complication. We are inviting problems. And this is the main problem we have it nowadays, because maybe a lot of people doing ACL, and sometimes they are not meticulous in proper site for the tunnel of the tibia or in the femur, then we are asking for problem, and this will invite failed ACL, and now it is very big entity, failed ACL. Failed ACL nowadays, we see it very, very frequently. How to fix the ACL? There is a lot of fixing device and also a lot of controversies in fixing. I left with the tunnel, but also in the tunnel there is a lot. Shall we do it double bundle reconstruction, anteromedial postlateral? It takes many years as an era. Let us repair, let us doing a double bundle reconstruction, but as all of you know, that the results of double bundling is the same as single bundle reconstruction. How to select the footprint of the ACL? Shall we do it anatomical reconstruction? And this also nowadays, the main is the anatomical reconstruction. To doing the femoral tunnel, shall we do it transtibial or shall we do it transportal? A lot of controversies, as I mentioned. Then how to fix the graft? Fix it by smart screw, fix it by transfixing device, like Mighty, like how to fix it by, is it adjustable rope or fixed loop, all of this, a lot. But be sure, please, that it is rigidly fixed, and check everything after fixing. Check by the probe, check by the scope that it is rigidly fixed. The ACL is in the proper site and the proper tension. As we said, the physiotherapy, we said it is teamwork. Who is the team? The team is the doctor, the surgeon, the physiotherapist, and the patient. These 3 persons are responsible for results. So the result, if there is any defect of this link between the surgeon, the physiotherapist, and the patient, the result is less. What the physiotherapy will do? Physiotherapy will help us to prepare the patient for surgery by getting range of motion, by strengthening exercise. Post-operative, they are the main role done post-operative is the role of physiotherapist. to get the range of motion, to strengthen the proprioception. Actually, the role of physiotherapy is very, very great for the lizards. I just bring this video to ensure, to again say it is teamwork. To get enjoyable goal, to get it properly done, it is a teamwork. ACL without complication? No. It may have complications, although it is not common, but nowadays, as I said, there is now failed ACL reconstruction, big entity, a lot of cases coming with ACL fail. What are the causes of fail? There is many causes. What failed ACL means that the patient may have osteoarthritis, may have stiffness, may have limited range of motion, may have instability, and may have wound complication. The big entity we suffer from is osteoarthritis and stiffness. Osteoarthritis may be due to, as I mentioned before, due to the recurrent attack of giving way if the patient came late, maybe due to the first vigorous trauma. If the trauma is very vigorous, this trauma to the articular cartilage will lead to osteoarthritis. But it is not, there is no osteoarthritis alone. We can say osteoarthritis is due to the patient has ACL, although he has no giving way. No, if it happens, it is mainly due to the primary trauma or recurrent attack of giving way or abnormal positioning of the tunnel. As we can see here, we can see how osteoarthritis happened in this patient in the 3 picture. This is the sign of radiological sign of osteoarthritis postoperative. We can see this patient in the left side, he did 3 ACL reconstruction. The patient may have stiffness or limited range of motion. As we can see here, this is patient on the right side have limited extension, maybe due to cyclope lesion. Maybe, as you can see in the X-ray on the left side, due to bad positioning of the tunnel, tibial and femur, this is give us limited range of motion, lack of extension or lack of flexion. As I mentioned, patient may have recurrent attack of instability, maybe have due to retrauma, maybe due to bad positioning of the tunnel, which lead to rapidly tear again, maybe due to the patient himself is negligent. All of this can lead to recurrent instability. As I mentioned, this patient has 3 times ACL reconstruction. Complication of wound, this is very infrequent, very rare we see it, but we may diagnose it. At the end, I just want to mention and emphasize that ACL management is a teamwork. Patient selection is very important to get the good results. Meticulous surgical technique. It is not very rapid, very quick. No, please take the time to properly do the tunnels, to properly fix the graft, and be sure that everything is okay before you go out. And physiotherapy is emphasized again that it plays a very great role to get the good results. Emphasize again that it is a teamwork. I'm very sorry to emphasize this several times, but really it is enjoyable to have team like that to score goal like that. Thank you very much. Thank you.